Welcome back to the Atlas of Chiropractic podcast. Got Dr. Bearder here with me and Dr. Brett Lux from St. Louis, the Saint Lunatic himself.
That's
where
new.
where the players play. That's a throwback. I'm showing my age. Dr. Brett and I connected on social media. This was probably, I don't even know when it was, Doc, but you did a Facebook Live on the Centeno Schultz page, and we're talking about your experience with Regenexx for your own case, and just talking through your experience as an upper cervical chiropractor. And I thought this would be a really, really fun, maybe fun's like a little bit of a poor choice of words there, but this would be like an interesting story just for docs to be able to relate to folks that have been down that road, to be able to identify those situations and understand the solutions available, because you're living proof of the benefit of these things working together as a nice combination of treatment. So first, let's get a little bit of background on you. Where are you from? How'd you get into chiropractic? And we'll go from there.
Yeah, so born and raised here in St. Louis, went to Logan with all us brown thumbers out here. And
here we go. Yes.
I actually don't do it. It works great, but I don't do it at Logan Baser. But practiced out in Kansas City for a few years. I'm with Dr. Andy Harding. Loved it out there, loved the city, but eventually moved back to St. Louis, where I am here now with my family. And, I started out full spine adjusting, traditional, diversified, like we were joking before. Well, I'm not too excited to stay, but I used to be a classic, rack 'em and crack 'em chiropractor, and came back to St. Louis, and I was still doing that for quite a while. And that's kind of when I realized, one, I wasn't getting quite the results I wanted, but two, it just beat the living hell out of my body. And so that's kind of when the whole CCI kind of started, is once I started realizing, okay, I can't do a single T to A without curling up. Essentially, it was that bad. So, but yeah, as to how I got into chiropractic, I don't have any fun, miraculous story. I just simply always, I was always fascinated with optimizing the human body, whether it be, working out, nutrition, nothing too exciting. But my story kind of started with that. I was lifting so much to the point where I was like, you know what? Let's make a sport out of this. I hired a coach. I was going to do a physique competition. And before I know it, I'm doing military press, way too heavy than I should have been. Boom, felt the pop in my lower cervicals. And ever since then, that was what 6 years ago? Ever since then, I've been fighting that battle.
Okay.
So, so that started back in, I don't even know what year that was. And I was still a young, naive chiropractor. And I just thought, oh man, I got lower neck pain. I got shoulder pain. It's a shoulder issue. I'm chasing shoulder stuff all like for 3 years straight. And and I tried everything, so started out, traditional chiropractic, diversified, and never got better. If anything, I was getting worse, and I saw quite a few people in Kansas City. I did prolotherapy. I did physical therapy. I did massage. It got so bad. Hell, I was doing Reiki. I was doing dry needling. I was doing soft tissue work, Rastin, SOT. I tried every technique out there. Nothing worked. I was just going downhill. So, and I won't lie, the story's kind of long. However, what I do want to explain it to where some of the doctors listening can really kind of show this podcast to some of their patients. So that one, I can teach these patients, number one, what doesn't work for CCI, which is just as important. But number two, of course, what works, at least for me. So before I continue, did you guys want to add anything in there?
No, I think it's a story that we've all heard hundreds and hundreds of times from folks that come into our offices, right? Which is things can seem very mundane or benign on the surface level. And a lot of times they are. And you go through, conservative treatments. And for something like a straightforward musculoskeletal, sprain strain kind of a thing, any of those techniques would have probably provided relief, right? And it's also, one thing I was thinking as you were talking is like, man, all these providers found something, right? Like as they assessed you through their systems, whether it was the soft tissue or the chiropractic techniques or whatever, there was always findings, right? They're like, okay, I think we're onto something here. And so I think we got to remember from a patient's point of view that like doctors are people and they have their limited perspectives a lot of the time. And so if you approach a new practitioner, they're gonna they're going to have a certain set of criteria that they're thinking about helping you through, and they're going to do their best with that. So if you're frustrated with your lack of results, I think, the part that you're about to get to is the part about don't give up. And I was just telling a lady on the phone the other day, you sure won't find your answer if you quit, right? Like there's something out there. There is a thing that can be done to help your life get better. So definitely don't quit. We're checking things off the list, right? We're starting to narrow it down to the nitty gritty, like more specific niche things, but, stay the course. So that was the only one bit I'd like to add.
Yeah. I mean, it can sound cliche, especially when you're like in the trenches and you're in, horrible pain. But for anyone listening that has this, like you might be thinking, yeah, but you're a chiropractor. So like it was easy for you to find these people. Trust me, this had nothing to do with what I knew. I mean, I had the most debilitating pain. I would literally crawl in bed at night. Like, I sound like I'm being dramatic, but literally I would go home a grown ass freaking man, cry because I was in like so much fucking pain. So like my issues were all like upper neck, lower neck, classic discogenic pain into the, rhomboid area. And then, the referral was so bad, it just turned into a rotator cuff issue. So I left Kansas City, came here to St. Louis. I was still so effed up. I was like, I can't practice right now. So I took a full year off. I'm delivering FedEx packages as a chiropractor. And finally, one of my buddies, Dr. Ryan Warren, he's out in Arkansas. I mean, I owe him my life. He found Centeno Schultz Clinic. So that's where the process started. So the way it goes with the Centeno Schultz Clinic, you're going to sit down, do a virtual consultation with one of the doctors there. We'll go over really what's going on, and then they're going to send you out for the appropriate imaging. So the imaging necessary for at least what we thought, because we had no idea that CCI. We just suspected classic mid to lower cervical instability. So I had, normal supine MRI, x-rays, stress films, flexion extension. And then we knew we were going to do a procedure. So you fly out to Colorado, and then Dr. Evan Katz, he has a digital motion x-ray out there. We do some motion pictures, confirm, okay, yeah, very clear C3, C4 translation, C4, C5. MRI also showed bulge. So we went in, and did what we call posterior work. So posterior work, we're going into the inner spinous, intraspinous, inner transverse process ligaments. We went into the disc as well at C3, C4, C4, C5. The shoulder was so jacked up as well that we went ahead and went in with into the rotator cuff itself. So first procedure, honestly, almost no relief. I mean, pretty much nothing. Second procedure, like 6 months out, we did the exact same thing. Had a little bit of relief, but then again, I'm manually adjusting patients. So it just goes completely back. So finally, Dr. Pitts is like, okay, we got to change something up. We do a little more thorough, consultation. And he's like, I think you might have CCI. So normal thing, get more imaging. We go back to Colorado. Dr. Katz, takes a closer look, and he's like, yeah, I mean, this is pretty classic CCI. I mean, my AP open mouth, just static x-ray, lateral bending, was like 7 millimeters.
Yikes.
Yeah. So, which is cool to have that imaging to show the reduction in translation post, these procedures. So yeah.
And just as before we get too far down the road on that, so you're talking about going for the posterior work, these kinds of things. For folks that don't know what the treatment is that you're talking about, yes. What are they going in and doing there?
Yeah. So what they're doing is they're injecting PRP and stem cells. So what's that process look like? Well, because you're traveling, for me, they do basically everything in 2 days. So I go there on a Thursday. We do a more thorough consultation, do a real thorough examination with Dr. Pitts. And he's like, okay, according to what we found, putting it all together, imaging, exam, what you told me, the way everything manifests with pain. He's like, okay, this is where we're going to inject these specific levels, these specific ligaments, these specific, facet capsules. So the next day you wake up early, you go in, they draw your blood so they can spin it down for PRP. And then they also will pull out the stem cells from your bone marrow. So the way they do that is they give you a volume. You can choose fentanyl. It's a real low dose. They kind of put you in a low anesthesia, but I just choose the volume because it is kind of painful. They put a big needle in the iliac fossa. They put it right in there. They pull out the stem cells, and then they're like, all right, go do whatever you want to do. You're not supposed to drive, but I was good. So I go and take advantage of Colorado. I go for a little hike, even though I'm in pain. And meanwhile, they're at the office. They have their own lab where I don't know the exact process, but they have a unique way of a very more high concentrated stem cell injection.
Right. Yeah, I've been up to the clinic there to observe Dr. Pitts do these procedures, and the facility is impressive. I mean, they do have a full-scale lab downstairs, and so these are not like products they purchase, right? Everybody's like biologics, their orthobiologics are blood products that they harvest your tissue, and then they basically spin it down to whatever concentrate they think is appropriate for your situation. So they have, I guess, full customizable, range of things they can do with those. The stem cells are, obviously, like, just to not get too heavy into the microbiology, but the benefit of stem cells is like they can differentiate into different types of tissue. Right? So for healing, you've almost got this like template cell. And if you want to create ligamentous tissue, right, you can, put that stem cell in that tissue and have it differentiate into the appropriate type of collagen and heal the tissue as if it was never injured. Well, I shouldn't say that, but platelet-rich plasma, PRP, is a little bit different in that is more of a product to stimulate like a natural immune system reaction or like an inflammation in the area to promote healing. That's my understanding. Is that correct?
That's 100% correct. Yeah.
Yeah.
Which is a good point too, because this is not just a injection, you feel better. This is, you got to leave your body, let it do its thing, because it's your natural way of healing. So
right. Lots of folks have had, lidocaine injections or corticosteroid injections. That's not what we're talking about. We're talking about products that are designed to leverage the body's healing capacity and properties to make the tissue better rather than just to, let's say, decrease pain or inflammation. So,
and it's important that we differentiate, your own stem cells from your bone marrow compared to what you mentioned, which is, some of these proprietary blends. Those Dr. Centeno's done a lot of research on. Stem cells don't travel well. And so whenever you go to a doctor and they're like, yeah, we got like this stem cell jelly or something, we got this stem cell, whatever. Was it at one point? Maybe. But what the research shows and what the lab work shows is that most of those stem cells are dead by the time they're injected. So did it still work? Kind of, but nowhere near what I was doing. Because some of those stem cell, proprietary blends have different healing factors, and that, I don't know as much about. However, you're not getting true stem cells. So yeah, they pull out the stem cells, spin it all down in their little facility downstairs. Super cool clinic. You come back in, they hook you up to your oxygen. They put in, the anesthesia. I personally love going. It's kind of fun. You go in there. One, you have a level of hope because, like, holy shit, am I going to finally live like a fucking good life? I don't know if there's cursing on this.
You're good.
And but two, it's just like they're really nice there. And they make you really comfortable there. So, and you just feel really optimistic because it's like finally someone's taken the time to really like look into your case a little bit more and give you some hope in your life. So they put you under, and then they're going to do, so like my first procedures was only the posterior work, meaning just like the mid to lower cervical facets and ligaments and the disc itself. Like I said, my first two procedures, minimal improvement. My third time I go back, the same process, Thursday exam, Friday morning lab work. The difference though, now that I'm back for CCI, and for those of you who don't know, we keep saying CCI, but Craniocervical Instability. The difference is you can't just inject a needle in the back of the neck. You can't reach some of those supporting ligaments like the apical and the transverse ligaments. So Dr. Centeno, the cowboy he is, decided back in the early 2000s, hey, I'm going to go through the throat and inject stem cells that way. So when you obviously are, in that sensitive an area, close to the brainstem, you are like the highest level of anesthesia. So this setup is a little bit different. Once they prep you, they give you a lolly that has like a lidocaine on it, and you suck on it, and you just, lose a lot of that sensation in the back of the throat. And then you gargle like an antiseptic with some lidocaine in there as well. In my opinion, the worst part about the whole process is the lollipop and the mouthwash. It's so gross. But everything after that, people are wondering, like, are you in a lot of pain after? Are you real sore? Yeah, absolutely. Like, your throat is super sore. You just had needles go through there. You wake up, you're just so out of it. Throat hurts, neck is super stiff. And then I go home, or rather I go back to a hotel. You want to make sure you have someone with you because you're kind of useless at the time. And then the next day, you wake up and you're obviously still super sore. For me, everyone's different, okay? For me, I'm in still quite a bit of pain 24 hours out. 48 hours out, I'm feeling a little better. And then 72 plus, you're just super stiff with, a little bit of pain and like the normal pain. So then the healing where that starts, everyone's different. For me, it's clockwork. I always start noticing a difference at 2 months out every single time. Some people are 3 months out. Now, keep in mind, like Dr. John was just saying, it's going to create an inflammatory response. You're going to, a lot of times, feel way worse when you get like the first months. Like you'll feel like, did I just get worse? What in the world's happening? Like give it some time, be patient. 2 months out for me, at least, everyone's different. I start feeling better. 3 months, oh, I'm really feeling a difference. 3.5 months, then, I really feel a difference. However, I was still manually adjusting patients. So I was just, screwing it up. Every A to P move, oh my God, it'd feel like a freight train hit me. I don't even really do A to P anymore. So I'm sorry, P to A, that's what I meant to say. Really both of them. So my first pickle procedure, PICL for CCI, was where I got the most relief. Okay, great, we're on to something. Then I get in a car accident. Someone rear ends me.
No.
Yeah. I get in a car accident and the normal right-sided stuff flares up. I never had left-sided stuff, and if I did, it was very minimal. So now I got both sides going on. So thank God we have all of that imaging from the past, because now we can show, hey, here's where, Brett Lux was before, here's where he was after the accident. The DMX was just a gold mine for evidence to basically refute anything that the auto insurance tried saying. We battled up for a while, and honestly, I kind of had fun, like, with the insurance company, because it was like, you guys clearly don't know anything about this. Like,
No.
you guys are like, you guys think it's a strain, but have you guys ever seen a digital motion X-ray? And they're like, what's that? I go, exactly. Stop looking at the MRI. The MRI only gives you, according to Dr. Pitts only makes the MRI about 10% of his decision making. He looks more at the exam and more at the digital motion X-ray. So I get into the car accident, and fast forward, I have another pickle procedure. So now we're on to like the 4th or 5th procedure, something like that. And I'm doing much better, but still, like, it's a struggle. I'm thinking about closing practice. My technique's going to shit. You're in so much pain. So I'm still like letting the stem cells do their thing, but I'm like, there's got to be something else going on. Like, maybe I've got some sort of systemic inflammatory issue going on. I go and see a functional medicine doctor. And holy cow, did I find stuff I did not expect to find. So I had Lyme disease as well, mercury and lead poisoning. Then do you guys know what's one of the main lab work to look for, like, just in broad terms, like general,
Like a CBC?
No, general digestive, or like inflammation,
like a C-reactive protein or
reactive protein. So he sees a lot of people here in St. Louis. The dude's a wizard. I'm Dr. TJ Williams. And he's like, man, he goes, I do a lot of these. And he's like, you have one of the most inflamed guts I've ever seen. I have the CCI in conjunction with, heavy metal toxicity and Lyme disease. So I talk about this stuff because a lot of times you might need a little more than just simply stem cell, PRP, ligament injections. And for me, that's what I needed. So, we were doing everything from, cleaning up my diet according to my blood work. We did urinalysis, fecal analysis, we did swab, we did everything. I do ozone therapy. And then, are you guys familiar with EBU?
No.
So ozone therapy, you guys have probably heard about. Pull the blood out, pump the blood with ozone, you put it back through. It's going to help with mitochondrial function. EBU is ozone, but like a ridiculous amount of concentration. It's one of the more common things they do over the UK. It's not as common here. So we're doing that. We're doing chelation therapy, a lot of ozone. I was even doing, have you guys ever heard of insufflation, rectal ozone therapy?
I've heard of insufflation. I didn't know you could do it rectally.
Yeah. So that was fun, 3 times a week, sticking things up my butt. But
hey, people go to great lengths to get better, man. You do what you got to do.
I would have done some crazy shit if they told me it worked. So, but it was working. Okay. So my threshold, because you got to remember, when you're in this much pain, you will do anything just to lower that threshold of pain. Threshold rather. So all that stuff helped at least raise my threshold to where I wasn't triggering things as much. but my instability was just so bad at multiple levels. So I had to do a lot of procedures. Now, everyone listening to this, I don't want you thinking that I got to do all these procedures. It's so expensive. It is pricey, but most people are going to get 1, maybe 3 procedures. All right. I had 5 or 7 because it was so bad and because I was beating myself up here at the office.
Let me ask you this: just what do you think caused the CCI in the first place? We didn't talk about that, but so the lifting was obviously the straw that broke the camel's back kind of a thing.
Absolutely.
I don't know that you could rupture an alar ligament lifting overhead. That's a tough one for me. But do you think some of these, like, inflammation kind of a things? Do you have any family history of autoimmune stuff? Like, what do you think caused the CCI in the first place?
Yeah, that was a question of 4 years. I was trying to figure that out. So this is what my theory is I think, lifting overhead was more of an injury at the mid, like disc issue. Okay. That's where that was. I also working in a practice that was seeing like 800 patients a week. So I was adjusting. I went from 0 patients to like 150, 200 patients a week. So I was a real quick, but at the same time, we know hundreds of chiropractors that adjust tons of people. Why are they not getting it? I have one of the worst looking necks. I have a horrible C curve. I'm sorry. I wish I had
S curve.
I wish I had a C curve. No, I have one of the worst S curve. So, Dr. Evan Katz has done a ton of research showing how that S curve will just F up that upper cervical complex.
Yeah, it's just under tension constantly.
Exactly. So I think while my spine was just essentially just in a bad, predisposed position, it wasn't until boom, lifting overhead, boom, adjusting patients, and then boom, the car accident.
Yeah. That's what I wanted you to bring up is, for a lot of these things, we're trying with folks to connect dots and do the detective work of figuring out, like, how in the world did I get to this place that I'm in? Sometimes it's after the car accident. A lot of times it's like, I've just been getting worse, just doing my life. You're a fit, healthy guy, you're working out, you're doing good things for yourself, and all of a sudden it hits the fan. It's like, it's very unfair. And a lot of times the hard work is in the detective work. It's figuring out, like, what things haven't we thought of that could be contributing to this picture? And then how do we have thoughtful strategies to attend to those individual, like, the layers of it, because it's usually not just one thing. There's lots of folks in this world that have EDS and hypermobile autoimmune conditions and connective tissue disorders, and on top of trauma, and who knows whatever else. So it's definitely, it's not as easy as, like you said, you take the lateral bending x-ray or the flexion extension x-ray and you extrapolate everything. There's a lot more that goes into the determination. So I appreciate Dr. Pitts' perspective of, let's triangulate these findings. We've got our imaging findings, we've got the patient's presentation, we've got our physical exam, we've got our experience working with people. Let's make sure that we're doing the right thing for the individual.
No, absolutely.
That's interesting, Doc. That's interesting that Dr. 10% for the MRI. Like, that's, at least in the upper cervical world, a certain subset of upper cervical chiropractors rely heavily on the MRI.
Yes.
I'm not saying that we shouldn't, but something that I think upper cervical on the whole has been missing is motion analysis. And Stenberg knows, and anyone that follows me on social media has heard me speak at conferences knows that I've been taking end range scans in cone beam, and like, there are things you can see on 3D that you can't see on a digital motion x-ray. But when it comes down to it, I think it's 50-50. It depends on the case, but motion analysis is something that we are missing in the upper cervical world, like, sorely, really, really sorely. We can take our APOMs and or the lateral flexion APOMs, but the finding on a static MRI and even a cone beam, that's it, right? It's a static finding. You have no idea what this looks like in a person that's moving and grooving. And in a perfect world, we would have a cone beam and a digital motion imaging suite in every office, and we would be able to understand the motion with the staticism, as it were. But that's really interesting to hear the medical side of things, or at least their approach and his thought process, Dr. Pitts, with 10% of the MRI.
Well, just as a plug then, I'm working with Dr. Pitts on nailing down a time to do the podcast. So by the time this comes out, keep an eye out. In the next couple episodes, you'll hear from Dr. Pitts himself, and he can weigh in on that a little bit more. We'll make sure to ask specifically,
I'm
how
just a
those
lowly
criteria
co-host,
break
man.
down.
I don't know anything.
Well, even the regenerative medicine space, I mean, okay, so Dr. Centeno has been researching and working on this for 20 years. That's next to nothing in terms of getting FDA approval, having these procedures be very well documented, having high powered research studies to support, efficacy over time. He's pioneering. I mean, this is a new thing, and so when you're doing new things, there's inevitably iterations and there's learning as you go. And I know that they've changed the appliances to place the needles a couple times. They've refined procedures. There's different approaches now than there used to be. So it's a work in progress for sure. And
in only 20 years, isn't that interesting?
I mean, the thing where he started, holy cow, they have changed and they've constantly, like you were just saying, John, they've constantly fine-tuned everything. Every time I go in there, they're changing up the procedure and everything. It's impressive.
Yeah. Yeah. And there's just to be clear too. So they have a clinic in Cayman Islands, right? So they can do procedures there. They have their clinic in Broomfield here outside of Denver in Colorado. But and Dr. Centeno talks about this on his stuff a lot. It's we're the only ones doing this PICL procedure. So if there's someone else saying that they do a version of it or something.
There is someone in Europe.
Okay. So they are the ones that train, and they do have fellowships that they train folks to do these procedures, but it all comes from this one clinic. Mm-hmm. Right? So these are novel procedures that Dr. Centeno and Dr. Schultz and their team have developed over the course of years. And there will be others that come along, I'm sure, but it all kind of stems from this one guy's, personal practice, which is fascinating.
It really is. Yeah.
I think it's equally fascinating that obviously his career has been more than 20 years. We know that, but
of course,
it's when and I'm not beating down on upper cervical here, but it's very interesting that you have someone who has been pioneering this for 20 years, but yet you have the upper cervical subset of chiropractic that's been around for,
say 100.
Sure.
Say 100 years.
Jesus, 100 years. And we haven't really refined it, right? There's room for, I'm not saying that we should or shouldn't, but it's very interesting. And we can make the argument this is an invasive procedure, upper cervical isn't. But where's the innovation been on our end of things? And no one can convince me that upper cervical is that good. It doesn't need to be refined. That's crap. It needs to be refined. All of it needs to be refined and improved. And my hope is that cone beam and digital motion imaging or some combination can help do that. Because there's a lot of things we don't know about the upper cervical region. And I think it'll probably be our generation that ends up figuring some of these things out. Brett, you having lived through this, you may be one of the people that figures something out that we haven't figured out, because it's so close to home. You have the conviction that John and I lack when it comes to this type of stuff.
Selfishly, when I'm studying for something like that, I'm studying for myself. So it's it's kind of easy to study for it.
Yes, exactly.
And kind of piggybacking off of what you just said about our lack of innovation, that is one thing. When you're injured, you get really bitter and you get really pissed off. And I grew up Catholic, and so I was mad at God. But anyways, what I'm getting at is what I get really passionate and just fucking mad about is when you go into a lot of these upper cervical chiropractors. They're good people, they mean well, but they're so goddamn dogmatic. All they will look at is just the atlas, and they forget, instability is a thing. And they don't realize, just adjust the atlas. I'm like, dude, that is not it. You don't even know the closest. It's not just a simple misalignment pressure on the brainstem. And so that's one thing I want to talk about in a second is the stuff, at least for instability, you have to add. Upper cervical is incredible. It works super well, but let's maybe put our foot on the brake here and not get too crazy, because sometimes you got to add something. And if you do, either one, add it to your office, and if you don't, that's fine, but refer out and give a transparent explanation to the patient. Otherwise, you're going to string them along. They're going to get mad at you. They're not going to get better. And then worse, they're going to give up. And then they're going to live their life like that the rest of the time. And so that's why I get so passionate now with these patients that come in, because I almost gave up so many times. holy shit. I mean, because so many empty promises and people who just think, this is what I do, so it's going to work. And they put you through, the funnel. It's just,
Where did you get did you get upper cervical care somewhere in this? Where was that?
So I was, unfortunately,
In the timeline. In the timeline. Not who did you see, but like, where was it in the timeline?
Yeah. So I never really got it until I got to St. Louis. Like, I don't know. I started maybe 4 years ago, and I was getting, I won't say who it was, great guy, but he was doing, knee chest.
Oh,
That's one of the worst things you can do for instability.
yes.
I was dumb back then, and I didn't realize what the fuck I was doing. So the very first adjustment, I was like, dude, that's good. And I actually did feel like, you could tell, like my brain cleared the next day. But after that, nothing better. If anything, I was getting worse. I don't have anyone, unfortunately, in St. Louis that I trust. I do. Let me take a step back. I was seeing Dr. Eddie Weller. He does do toggle, and he does have a good technique where he's like, so I see and Weller has helped me out. But what I will say, in my personal opinion, if you're going to do upper cervical with instability, you got to, you know what I'm going to say, NUCA, orthosphinology, and AO. Those are the three. Would you guys add another one?
No, that's about it. Instrument-based technique or light touch.
Yeah. You guys both do NUCA, right?
No, neither of us
I do
NUCA.
Blair.
Oh, Blair? Okay, gotcha. So,
I've got this thing back here.
is that an AO?
It's a original CBP table mount instrument.
Oh, nice. John, so you do Blair. Do you see like pretty like good results with CCI with Blair adjustment?
Yeah, I've had very minimal trouble with it. I don't adjust those folks unless I'm confident they can handle it. And obviously we modify technique and do it accordingly. But one of the things I appreciate about Dr. Pitts and their crew in general is they're very pro upper cervical care. And he even mentioned to me, he's like, it's good to know you're in the Springs. A lot of times we want people to try upper cervical care before they get these procedures. If you can create some dynamic stability, with your procedures, then great. It's either set them up for success with the procedure or maybe put off the procedure or whatever. So I do have folks that I manage with CCI, and, we adjust very judiciously and sparingly, and we have to, this is the thing, like you just said, I didn't know any better. I went to this knee chest guy. Shame on him. He should have known better, right? If you're having folks come in that have these conditions and you claim to be an expert in the upper cervical spine and you don't know the first thing about it, and you're going to put people down on a table and do your thing without accommodating to the differences in the presentation, that's a problem. And that's where we got to step our game up. And even if you're a philosophical chiropractor, right, limitations matter. It's built right in. Sometimes, there are just some things that are not going to magically resolve if you get a straight line on your Titron scan. Anybody can argue with me about that. That's okay. But the point being, I am trained in Blair. I know some other technique stuff too. But when these folks come in, I just had a conversation with a lady the other day, and she's been doing great. She held her last adjustment for a month, which is killer for her, and hasn't had headaches and, this kind of stuff. She's back and forth, like, do I do the procedures? They want me to do the posterior first, and then I probably need the PICL, but I can't do anesthesia because of this thing. So there's a lot of managing cases and patients like this is not a quick subluxation check per se. Like there's a lot of other conversation, a lot of other things that go into it. And so yeah, I've dealt with these folks. In hindsight, I also dealt with some of these folks that I didn't realize I was dealing with before I knew better. And some of the folks that didn't get better, now I have a better understanding of why and the things that I missed, the things that I didn't know. And, they're probably out there in the world having had a poor experience with upper cervical because of my ignorance, unfortunately. But yeah, I think the saving grace of like a toggle or a Blair adjustment or on that type of table is that it doesn't have a mastoid support. Like the headrest is squishy. There's a big gap right under the atlas. Like it's not leveraged as mechanically as what you guys do on a mastoid support, in my opinion. But you definitely have to you got to be careful with it, and you got to know sort of like how to modify your technique for it.
There's two things that I think need to be teased out and pulled out because they're really good. John, you said, shame on that knee chest doctor. I would agree. However, there's a lot to unpack there. We could sit there and dissect that what it comes down to is it's 2025. There's no reason not to have the wherewithal. And, maybe that's something the upper cervical diplomat should do a module on, and maybe bring either Dr. Pitts or the Centeno folks in to teach that module, because unfortunately, for anyone who peruses the Craniocervical Instability Facebook groups, upper cervical doesn't have a really good reputation in these groups. And that's a shame, because if you have the world's foremost expert saying that they want their patients to see upper cervical chiropractors, but then you go and you look at the patient experience and it isn't good, where are we missing the mark? Like this, if there's ever been a unification, as our friends in St. Louis like to talk about, if there's ever been a unification of the profession, maybe, or the upper cervical groups, it should be on this. Huge. Because it's going to sound really bad. It's low-hanging fruit, for the love of God.
Yes.
Like, all it takes is an extra little bit of time to understand the signs and symptoms, and then the evaluation to say, probably shouldn't touch this person because the likelihood that it's going to go bad is somewhat high. Yes, they're subluxated. Not a good thing. But you know what? If you go and you smush their neck with the old KC, it's probably not going to do very well. Second thing, dynamic, John, what did you say? Dynamic changes or dynamic stability. Dude, we need to trademark that, because that phrase right there is a short 2-worded explanation for why upper cervical probably works. We ain't taking pressure off the brainstem. We're creating dynamic stability with regards to how the muscles interact with the position of the segments, and how the muscles interact with the movement of the segments and the biomechanics. That is freaking, as John Chung said earlier today, that's the gold nugget in this little foray right here. Dynamic stability is the name of the game. And that's what we provide. Truly, that's what we provide. How do we know that? Neck care. That's not a shameless plug. But truly, that's how we know that we're providing dynamic stability, is we can now actually quantify how things are moving. It's amazing. Truly.
You know where I got that term?
Where?
Sports health sciences at the chiropractic electives. And this is weird. This is a weird thing that got me into upper cervical. People may not have heard, but I took arthrokinematics of the lower extremity class. So it was all about biomechanics and ground reaction forces and Greco-Vext's spinal engine and all that stuff, biotensegrity. But anyway, we were talking about how there are athletes that will tear an ACL, and rather than have a surgical procedure, they rehabilitate it to promote dynamic stability around the joint. It's if the muscles have enough tonicity and neuromuscular control and so on and so forth, the joint, I guess you should put it this way, you're not supposed to be hanging out on your ligaments all the time, right? They keep the bones together at the end ranges, but it's the other tissues that really keep things in a state of stability and motion. And so that came back up later in just this upper cervical, foray of learning. It's you know what? So, because I had this conversation with a lady, you can see that her alar ligament is calcified, it ripped, it calcified, and you can see it on the image. And we have the DMX to confirm she has instability. It's okay, so there's a lot we can do for that tissue in particular, but on the other layers of tissue out and around that, what can we do to bolster this system? Because if you rip up your ACL, you could put a dang knee brace on and go on crutches, immobilize it, and let it heal. Your head is always up. You're always holding your head up. It's always balanced on top of your spine, and it's moving all the time. So we don't have that same opportunity per se. And some people get into collars and stuff like that. But, we're kind of trying to rehabilitate it on the run, is what I tell people. You're moving and grooving and living your life, and we're trying to promote that stability in the conditions of your life, which is a little bit of an additional challenge. But yeah, that's where that came from.
Brett, what PT did you do?
Are you guys reading my mind? This is the most perfect segue, and I wanted to talk about the stability and PT, and man, all right. So this is huge. So for all you upper cervical docs, we know 9 times out of 10, upper cervical is going to help quite a bit. So a CCI PT comes in huge. This is at least for me, it did. I honestly saw the most quick changes once I started implementing dynamic instability. I'm sorry, dynamic mechanics. You guys got a new term on my vocabulary. So I owe my life to Dr. Ed Pilgrim. Actually, he's not a doctor, he's a PT. But anyways, Ed Pilgrim here in St. Louis, and I've worked with tons of PTs. He helped me with just functional movement stability. And one thing that I completely forgot, and really I don't even know if I knew that well, is just how much the thoracic spine, the scapulas, the chest, everything affects the neck. And so once I started working with him, I mean, man, that's why now like I can sit here and do this video and not be in pain right now. So like, I mean, think about it. I mean, that like what, for instance, for me, that levator scap, attaches to the scapula. Well, it goes all the way up the cervical spine, attaches to the atlas. If you're raising your arms constantly and that serratus isn't kicking on, that scapula is not going to downward rotate because that levator is so tight. So you want to go in, release that levator, activate that, serratus, make sure that, the dynamic, movement of those scapulas are properly moving. Otherwise, those scapulas are constantly upward rotated. Those muscles on the scapulas attaching to the atlas are constantly tight. And so you have to implement, at least for CCI, in my experience, some sort of functional movement PT. The problem is that a lot of PTs, from my experience, are just classic pulley system. Like, let's just, let's do our external rotation with the cable system. Ed, what he did with me, he did the opposite. What people are telling me, stop lifting overhead because you're putting weight on top of your cervical spine. And he's like, we're doing the opposite. I want you lifting overhead. I want to see that scapula downward rotate. I want to see that levator lengthen. I want to see those erectors relax. I want to see the rhomboid finally shut off so that that rotator cuff is actually doing the external rotation and not the rhomboid. And so I'm telling you, ET is an absolute must for at least for a quicker recovery and for a thorough recovery with CC.
Again, a knowledgeable PT, because these people a lot of times have tight muscles. Yeah. Like the body is aware of its instability and will often upregulate the tonicity of these muscles to protect. Right? So if you just go to someone who's going to dry needle and stretch you and do all this kind of stuff and sort of remove the natural guarding that the body is trying to use to protect itself without that more functional sort of comprehensive view, you're going to have problems. This is where people, I did PT and I flared really bad, or I went and got a massage. It felt good while I was on the table, and then I flared and had a week where I was in bed after that. You hear these things and it's like, okay, if we see that a muscle's tight, so what? What does that mean? Is that information telling us something about the system? And again, considering all those other things, it sounds like you had a guy who could think through that and then sort of look at the associated systems and go, okay, how are these related? What is the interplay between the shoulder girdle and the neck that is continuing to keep that unstable part of your spine under a stress condition and dysfunctional? And where are the opportunities to implement strategies that can restore normal function and sort of de-stress that naturally? And then again, like importantly, keep you engaged in your life, and in activities. Like, of course, you could just quit doing everything. And then what? You know what I mean? Like the whole point of having these procedures and getting better is so you can live your life, not so you can live in a bubble and just try to avoid anything that strains your neck.
Yeah, that's the way I was. I was seeing very minimal patients because I couldn't adjust anyone. And my dating life was non-existent because you're in so much pain. My social life was non-existent. Didn't see friends anymore. Didn't want to go to feeling parties. So again, I keep hammering back to, if potentially, hopefully some patients of the doctors listening, listen to this, like, you're not alone. Like, I know you go home and you think, how can I take care of my kids? How can I start a family? Like, I don't have a family yet, but how can I start a family when you're in that pain?
Yeah, it's powerful to hear other people who have walked down a road that you're walking down, and have gotten to a fork in the road, where things got better. We can talk to people until we're blue in the face about all of the things, but honestly, your story will resonate much more than any of the science that we could provide or any of the insights we think are, important. It's like, if people can associate with your story and can see light at the end of the tunnel and see now that you've re-engaged in all those things and that there is a path forward, that's what it's all about. And part of the reason why we wanted to have you on the podcast was, we have a lot of students that listen and we want them to be aware of this before they're practicing. It's like, don't get 20 years worth of upper cervical technique experience and then go, oh, wow, there's instability. It's like, no, now with technology, we can cut that learning curve. And for folks that may not have been aware, may not have had access to information to kind of put them onto it. We're doing what we can to try to spread the word and put a bug in students' ears that like, hey, this is 2025, if you're going to be practicing after 2025 upper cervical, you will see CCI patients and you will need to understand how to handle them. And it could be your first patient in practice. It could be 10 years into practice. Like, be prepared, start working on an understanding of these things and be familiar with the concepts. Like, you don't have to get it all figured out overnight, but familiarize yourself with the concepts, continue learning, accessing resources. I mean, you can go on a Centeno Schultz website, download their entire CCI book as a free PDF. It's killer. It'll get you up to speed pretty quick. And I'll make sure to put the links in here, as well as our link to the episode with Dr. Katz. Dr. Katz and I did a conversation about this. The Dr. Pitt's interview, we'll put a link there too, link to Dr. Centeno's Facebook page, because he does all kinds of lives and stuff. Like, there are resources available for you to get up to speed and get familiar with this stuff, so that you can be the one who sits across from somebody and says, you know what? I actually know what you're talking about. And I actually know how we can tease this out. And I know that there are things to be done for you in this situation.
So I don't actually, John, I don't even know if you know this. One of my first patients was a CCI patient. Like, one of my first patients at Keystone was a CCI patient. I will never forget, at the time I was referring for cone beam at a dentist's office about 4 miles away, and I'd drive to the office and take the scans, and I didn't know what I was getting into. This lady was she couldn't get up. So like, I'm wheeling this recumbent wheelchair through the dentist's office to the cone beam, and the staff is like, what the heck is going on? Right? I'm 29 years old, and I'm like, man, I'm going to figure this out. But like, I sat her up, and it was really hard. We did it in a chair. We took the cone beam, rolled her out, brought her to the practice, and I started analyzing it. And those were the days where I had hours in between patients. But so looking back on it now, what I thought then is she had the largest anterior atlas I've ever seen. But what I now know is that she didn't. She had the largest posterior occiput that I've ever seen. It wasn't an anterior atlas, but she actually had it bilateral. So it looked like a bilateral anterior atlas, which is a Blair concept. But like, the alars, but the C0, C1 capsule was so shredded that like, she had a 6 millimeter gap between the anterior portion of C1 and the anterior portion of the condyle. So like, I was like, oh my God, this woman's neck is about to fall off. Now, I used a torque release instrument in side posture, and I dropped the headpiece at the same time that I fired the instrument. There's no way that I'm going to I'm not going to Blair this lady. That's nuts. And she walked out, like, in a good way. We got her up. She was able to stand, and she walked out of the practice where we had to wheel her in beforehand. But like, yeah. The reason I bring that up is, if it happened to me, it's going to happen to some other student or some other young doctor. You're going to, and especially these kids are probably going to be on cone beam. They're going to see this, and hopefully they're going to think, well, wait a minute, do I really know how to handle this? Or should I talk to a colleague, or maybe I should hold off for a second and maybe have this patient get a second opinion from the Centeno Schultz Clinic, right? But there's no harm in taking a step back and saying, I'm not going to treat this person yet, because I think that maybe there's a step in between, or maybe they don't need treatment at this time because it potentially is unsafe. Like, and Brett, I know that you've probably suffered with this, and we all have. It's like, you want to help someone as fast as possible. You're like, boom, we just need to get them adjusted. No, like, take a beat, slow it down, and think critically. If it could be beneficial, it could also be harmful. And especially, Brett, with you having like a 6 to 7 millimeter overhang in lateral flexion, last time I checked, but all the other techniques put everyone in side posture, right? If you put that person in the wrong side posture and you freaking get them into a 7 millimeter overhang while you're about to adjust them, and then you kablamo, bro, that could go really wrong. And then we end up having a bad experience, and they go on Facebook to the CCI forums and say, this person ruined my life. I cannot tell you how many times I've seen that. It is so discouraging. It's so discouraging. It's you
And
know,
a lot of those that you see, it's AO adjustments.
it is.
People
Dude, well,
seek out
oh,
AO.
man.
And so it's just because your technique is low force doesn't mean that it's
No.
completely,
Yo, I'm gonna
benign
I'm gonna
as
go
a,
on record. I'm gonna go on record here.
here it goes.
100%. Here it comes. You're exactly right. It's not the 6-pound puff of air coming from the AO stylus. It's the position and the severity of how they set these people up. A hard mastoid with an extreme head tilt or an extreme height fact or whatever, like the headpiece is raised or the headpiece is tilted, that it's a 50-50 shot. It is Russian roulette, literally. If you set them up on the wrong side based on your technique analysis, you will not ruin that patient's life, but you will F that patient up. It's not No, you go.
No, to make a good point, like on one end, yeah, they're gonna get on like the CCI pages and say like this doc messed me up, but like I think of it like from my standpoint, if someone effed me up and I'm not gonna come back and then I potentially give up and I live that life, of pain. So like I had a perfect example on Thursday last week. It's so nice because I can relate to these patients now. And so I had a patient come in and she literally said, quote, "Hey, I don't want you to touch my neck today." And so I was like, "Hey, let's just do an exam. Let's see what we're doing. If you don't want me to, by all means, we can find other ways. I can refer you out." But then we get done with everything, and I laugh as I'm saying it, but I'm like, "Hey," I was like, "Tina, I'm going to be honest. I'm only going to touch one thing, and it's going to be your neck, and that's it." And so this is where the young docs should pay attention. The ones who are in that much pain, ease into it. Because if one, take your time, but two, they're so nervous. And so I told her, I was like, "Hey, why don't you come back on Monday with your husband? You two are going to sit down. We're going to take our time. But more importantly, I'm going to look at your x-rays like more closely." I could have easily adjusted her right then and there. But what if I messed her up? Like then one, yeah, sure, she's worse. But two, she'll never go to an upper cervical chiropractor that could have helped her. And so then she's in pain the rest of her life. So like think less of trying to get someone adjusted right off the bat just for like getting them to pay and get them in. Just take your time and then they'll be a lifelong patient.
Yeah.
Yeah,
That's
that's
right.
called patient-centered care.
Yeah.
Like showing them that you are listening, that you're understanding, that you're accommodating, and that your primary focus is on them. Not you, not your reputation, and not your results, and not any of that stuff. It's about them. And for her to go and have the weekend to just kind of think through it, reflect on her interactions with you, like build some confidence, like muster up the courage, if for no other reason, to get on the table on Monday and go, "You know what, let's go." Like that's awesome. And that's exactly what needed to happen. So I know you got to be prepared for that. And you got to this is where like a good history in the first place and good intake form and all that kind of stuff will make it less likely that you're jammed up in the middle of a schedule full of people and have one of these things come up and go, "Oh my God, like I wasn't ready for this. I didn't know it was a CCI deal. Like, shoot, well, we'll probably help. Let's hurry up and get you adjusted. I got a room full of people waiting." So you can get ahead of that if you just do a little bit of due diligence. But yeah, that's a great story. And I've had folks too with everything is telling me that like you could be adjusted today as far as like my chiropractic training, but I just don't have a good feeling about it. Like I am not comfortable. Like if it's okay with you, let's wait and then recheck, because I don't like when my gut doesn't match my science, and if it's giving me mixed signals that way, then we're just going to back off, because we can always live to adjust another day. But I'm afraid that if I adjust you now, you'll flare, or it just might not go well, or, we're going to have to do some cleanup work later, which is not what we want to do. So yeah, it's all that stuff, listen to that still small voice, as they say.
Brett, how did you get into upper cervical, man? Because like it doesn't seem like you directly inserted in. Like you clearly had the more medical upper cervical approach, but how did you arrive at doing this?
Yeah, I mean, dude, I knew nothing about upper cervical. Like
that's crazy.
In fact, I just thought you guys were just a bunch of freaking weirdos.
Yeah.
So
spoiler alert.
Yeah. What you don't know, you think they're weird. What you say, John? Do I think you're weird? Yeah, very weird.
Yeah. There it is. If you're listening to this, you're weird. So
yeah,
that's a good point. All you guys are weird listening.
So weird.
So I reached out to Dr. Ed Giglio, and so I asked him what's a low force type of technique, and so he geared me towards orthospinality. And another guy I owe my life to is Dr. Chad Delirious. He is one of the best teachers I've had in all of education. Holy cow. I mean, he's super smart, but two, he takes the time. And so I actually got on the phone with him and I told him my story about CCI. And I'm like, hey, I got to find a technique that's good for my patients, but not hard on my body. He literally goes, all right, man. He goes, when are you free next? I'm like, I don't know why. He's like, why don't you come up to my office, just you and me? I'm going to teach you orthospinality. He literally taught me one-on-one orthospinality. Basically a year later, 90, 80% of my office is upper cervical. And so if it wasn't for him, I mean, God, I'll be honest, I probably would have changed professions because there's no way I would have been able to continue manual. I still do manual adjusting because some patients need it. You guys know that. I know you guys do other stuff too. And
have you told him? Have you told him that? What you just told us?
Yeah, I've told him. I've sent him text messages. I've told the board so much. The board needs to start listening more to him because he's the young guy. He's the one who can relate to us the most.
He's not that young. He's not that young.
Sifu. Hey, you probably didn't know this about Chad, Brett, but he went to school with me and Cameron. We went to chiropractic college together, and that guy has lived many lives, like
so many lives.
He was like a martial arts, guru in Korea for years. He's an interesting guy. Yeah, shout out to Dr. Chad.
You want to talk about weird like you were? He's definitely a little nerd for sure.
Dude, so he did the first year of the diplomat, and we all had or maybe it was me. I bestowed nicknames on everyone, right. And his was Shifu, like the little character from Kung Fu Panda.
Okay.
Yeah. We didn't give him the Yugui. Yugui was like the master, right? Like the one who was had 1,000 years of experience.
That's Roy Sweat.
Yeah, that was Roy Sweat. But so
sorry, right?
Chad, Chad is good. Chad is very good. I actually saw him this past weekend in Atlanta at the Care Institute thing.
Okay, yeah, I was texting when you guys were there. I asked him a question about Parkinson's, and I guess you guys had just got done learning stuff about Parkinson's.
Something like that.
It was funny that you guys were talking about that.
Yo, Chad. Chad.
I just wish he could do every seminar because, I mean, as you guys know, orthospinality, or rather upper cervical, can be tough to teach sometimes, and especially orthospinality. And so he's just so good at explaining it.
Yeah, all these things take time, and I do want to emphasize that to students, if you're getting into upper cervical work, just be prepared to spend time on it. Just be prepared to study and to go to conferences and to talk to people and to read research and to, dig a little deeper. You know this from your previous work as a conventional chiropractor where, you kind of just loosen people up and you get into upper cervical. It's just a whole different ball game. So just kind of get used to the rhythm of that, get yourself in the habit of interacting with content and people and asking questions and going to conferences and getting familiar. We've identified and tried to be purveyors of a lot of these resources because there is quite a bit out there actually that is not upper cervical chiropractic content, but is upper cervical content, stuff related to the craniocervical junction that's really, really interesting and really important. And like Cameron has said before, it's like a little bit of a no man's land, right? You've got Centeno and they're doing their thing. You've got the upper cervical people, but this is such an important part of the body. And a lot of people are not really well equipped to handle it. So it's a big need to meet, but just be prepared to kind of expect a little more of yourselves and each other, and that's why we sometimes come off as critical because we see that there's a lot of room for optimizing what we're doing and how we're interacting with these people. We are positioned to be very uniquely valuable to folks in these situations if we are,
and students John makes such a good point. I mean, for lack of better terms, get used to banging your head against the wall after an upper cervical adjustment. For me, when I would get done with the post x-ray, I'm like, nothing changed. Holy cow. Or I took the plane line up. It's just going to be a matter of trial and error. You just got to be patient. And this sounds cliche, but it's true. If I can do it, trust me, you can. I am the worst student ever. I never went to class. I should be saying this on this podcast, but whatever. To add to the point, my classmates thought I dropped out multiple times because I would just show up for the midterm and finals. I was the worst patient ever. But now, it's simply different because I have patients that are relying on me, and two, it's selfishly what I deal with. So I love studying it.
Awesome. Well, we really appreciate the generosity of your time, sharing your story and your experiences with it. We'll keep having these conversations over time. I mean, this isn't going away. This problem is here to stay. And if anything, there's going to be more people being diagnosed more accurately and searching for more solutions. So we intend to be, at the tip of the spear, helping connect folks with information that can help. So I appreciate you, man. Any last words of encouragement or advice while we wind down?
Hey, thanks for what you guys do. I stumbled upon you guys' podcast, a few months back, and just listening to it. It's so great, just from from every avenue, whether it be science, whether it be patient centered, whether it be a little bit of philosophy, whether anything. You guys do such a good job. And I gotta figure this out. You guys have got to be the ones behind the Chiropractic Instagram page. I swear.
No. We've had that lots. I wish I could take credit. I won't out him, but it's not me.
If it's not you, do you guys know who it is? Yeah. Okay. Because the page is hilarious. And then the two of you also post hilarious chiropractic memes on your personal pages. So there's a little crossover here. So
hey, and by the way, I have reached out on multiple occasions to him about doing an interview because we chat back and forth, and he, so I'm still not. That's my white whale. I'm not giving up on him. I said we'll do a freaking we'll disguise your voice. I don't care. We could just have such a hilarious conversation about chiropractic.
Yeah.
So I'm not giving up.
Like they do with the drug cartel, like documentary with the low, deep voice. You guys,
backlit, all of it.
Oh, that'd be great.
Well,
that's pretty good.
We know that he listens to this, and maybe things will change. I doubt it, but a girl can hope.
Well, while you're listening, because it's obviously an upper cervical chiropractor.
It is.
If you're listening right now, get on my Instagram, Dr. Brett Lux. Say hello. Give me your first and last name. All right. I'm gonna do my research. I'm gonna figure it out.
No, you won't. I can promise you that. You will never. There are no breadcrumb trails. There are none.
Which one of you guys posted the one about BJ after Mabel died today?
That was probably him.
Oh, that was him. Okay, did you guys see that one?
No, but now I'm gonna rush right to it.
Yeah,
that is ridiculous. It's so funny.
Especially the times we're in. There's just so much good pop culture for him to memeify into chiropractic. It's great. Awesome, man. We'll let you go. You going to be out on any of the seminar circuits this year? Maybe ICA Forum, Orthospinology?
Some ICA stuff. Actually, after we get done with this, I'm going to reach out to you guys and pick your brain about, some seminars you guys recommend. Because I'm still a newbie. I still am such a newbie when it comes to upper cervical. So I need you guys to kind of show me the routes on seminars.
No doubt. Happy to. All right, guys. Cool. Thanks for listening, and like and subscribe. Hey, by the way, we have a YouTube channel now. So this is a full link. We'll be up on the YouTube channel. I'll put the link here in the show notes. I'm going to do a giveaway when we get to 1,000 subscribers. Don't know what it's going to be yet, but I just kind of said that. So it's going to happen. And check out the YouTube channel. That's going to reach more people than me sharing on my social media platform. But appreciate you. Have a good one.